Assalamu alaikum. I am Dr. Nabila, lecturer at Anatomy Department of Bashundhara Ad-din Medical College in South Keraniganj, Dhaka. Today I am going to discuss the topics about thymus gland. Thymus. Thymus is an important lymphoid organ situated in the anterior and superior mediastina of thorax extending above into the lower part of the neck. It is well developed at birth and continues to grow up to puberty, and thereafter undergoes gradual atrophy and replacement by fat. This is the diagram of thymus gland, and thymus is bilobed in structure and made up of two pyramidal lobes of unequal size, which are connected together by areolar tissue. Each lobe develops from the endoderm of the third pharyngeal pouch. It lies on the pericardium, the great vessels of the superior mediastinum, and the trachea. Small detached thymic nodule may be found in the neck. The thymus weighs about 10 to 15 gram at birth and 30 to 40 gram at puberty, and only 10 gram after mid-adult life. Thus, after puberty, it becomes inconspicuous due to replacement by fat. Now, the blood supply of thymus gland. Thymus is supplied by the branches from the internal thoracic and inferior thyroid arteries. Its veins drain into the left brachiocephalic, internal thoracic and inferior thyroid veins. Now, the nerve supply of the thymus gland. Nerve supply, thymus is supplied by the vasomotor nerves, which are derived from the stellate ganglion. The capsule is supplied by the phrenic nerve and by the descendant cervicalis. Now, the function of the thymus gland. Thymus controls lymphopoiesis and maintains an effective pool of circulating lymphocytes competent to react to innumerable antigenic stimuli. Number 2, it controls development of the peripheral lymphoid tissue of the body during the neonatal period. By puberty, the main lymphoid tissues are fully developed. Number 3, the cortical lymphocytes of the thymus arise from stem cells of bone marrow. Most of the, about 95% of the lymphocytes, T lymphocytes mainly, produced and are autoallergic and short-lived and never move out of the organ. They are destroyed within the thymus by phagocytes. Their remnants are seen in Hassel's corpuscle. The remaining 5% of the T lymphocytes are long-lived and move out of the thymus to join the circulating pool of lymphocytes, where they act as immunologically competent but uncommitted to cells. They can react to any unfamiliar new antigen. On the other hand, the other circulating lymphocytes are committed to cells. They can mount an immune response only when exposed to particular antigen. Thymic lymphopoiesis, lympholysis and involution are intrinsically controlled. Number 4, the medullary epithelial cells of the thymus are thought to secrete lymphopoietin, which stimulates lymphocyte production both in the cortex of the thymus and in peripheral lymphoid organs, and the competence inducing factor, which may be responsible for making new lymphocytes competent to react to antigenic stimuli. Number 5, normally there are no germinal centers in the thymic cortex. Such centers appear in autoimmune disease. This may indicate a defect in the normal function of the thymus. Now, the clinical anatomy of the thymus. Number 1, involution of the thymus is enhanced by hypertrophy of the adrenal cortex, injection of cortisone or of androgenic hormone. The involution is delayed by castration and adrenalectomy. Thymic hyperplasia or tumors are often associated with myasthenia gravis and characterized by excessive fatigability of voluntary muscle. The precise role of thymus in this disease is uncertain and it may influence directly or indirectly the transmission at the neuromuscular junction. Number 2, thymic tumors may press on the trachea, esophagus and the large veins of the neck, causing hoarseness, cough, dysphagia and cyanosis. This is all about the thymus gland. Thank you all for patience listening.